I bet we've all seen the t-shirt. Life's a bitch. Then you die. Well, the first half of that t-shirt is generally not accurate because for most people, life is a joy. And for people like all of us here today who have all the advantages that we have, life, I would expect, is indeed a joy. The second half of the t-shirt is accurate. The mortality rate is still 100%. And that's what I want to talk to you about today. I want to talk to you about dying better in America. Now, there's an old story among gerontologists, and what it says is that people should all live to a ripe old age, well into our 90s, and then have it end with a quick bullet fired by a jealous lover. But that's not the way that most people in America go into the great beyond. For many people, dying in this country is isolating, painful, and costly. And I want to give you some examples. First is my friend Tom, and here's what he said. Another trip to the emergency room in the middle of a frigid night was not what Mom wanted, nor was it what my sister and I wanted for her. Our mother was a proud woman who had lived independently for years with multiple chronic conditions. However, she was 85 years old and frail. And on this night, she had the symptoms of a mild stroke. So what else could we do? This was a recurring cycle over many years. Late at night, simple answers to simple questions did not come quickly, but were discovered only after putting Mom through tiresome rounds of ER protocol, CT and MRI scans, and countless forms to fill out. Communication among the numerous specialists treating Mom was seriously lacking. Now, this next one is from a college classmate, and she sent me this note about the final year of her partner's life. And she called her story, Coordinated Healthcare, Who's in Charge? And here's what she wrote. Here's a list of specialists he had to go to see regularly. Head and neck surgeons, 4 in the same practice. Medical oncologist, radiation oncologist, cardiologist, urologist, dermatologist, gastroenterologist, internist, 2 integrated medicine MDs, dentist, speech and swallowing therapist, and lymphoma therapists, and visits with a pulmonary surgeon, plastic surgeon, oral surgeon, ophthalmologist, and palliative care specialist. We thought the integrated care MDs or the internal medicine MD would coordinate all this. But no, even they were focused on their individual contributions. There were massive numbers of prescription drugs ordered at 2 different pharmacies, many of which had to be in liquid form, crushable or powdered, some requiring pre-certification from the insurance company, taking days and even weeks to complete. I now look at his medical history as a series of hurricanes that hit him, which he survived because his immune system, like the levees in New Orleans, held. Finally, the storm, like Katrina, was too strong. The aging process weakened him, and the levees broke. Now, this last one is by an author named Michael Wolff, who is writing in New York Magazine. He said, the costs for my mother, who is 86, and who for the last 18 months has not been able to walk, talk, or to address her most minimal needs, and who is absent short-term memory. Those costs come in at about $17,000 a month. And while her long-term care insurance hardly covers all of that, I'm certainly grateful she had the foresight to carry such a policy. But long-term care insurance helps finance some of the greatest misery and suffering human beings have yet devised. Everybody would manage his or her parents' decline differently, but we all mess it up. My family agreed with a cardiologist to perform surgery on my mother when she was 84. It did not occur to us to say, you want to do major heart surgery on an 84-year-old woman showing progressive signs of dementia. Are you nuts? The operation repaired my mother's heart. She can live for years, according to the surgeon, who we were never to see again. But before, where we were gently sinking, now we were in free fall. She was reduced to a terrified creature, losing language skills by the minute. She certainly appears agitated, the psychiatrist sent to administer antipsychotic drugs told me, and so do you. 6 weeks and something like $250,000 in hospital bills later, paid by Medicare, she was returned a shadow being to her assisted living apartment. 3 vivid examples of what it's like to die in America. Now, what do people want when they are seriously ill? The research tells us that they want to be at home with their families, their friends, their loved ones, that they want to have their pain managed, they want to have their spiritual needs addressed, and they want to make sure that their families are not financially and emotionally devastated by the experience. But you just heard what we get. What we generally get in America is aggressive care, even when perhaps it's not warranted, even when it doesn't square with what patients and families want or what their values are, and even when it's not going to maintain a quality life. And we get very high costs, and we get the kind of anguish and concern and, yes, fear that those examples gave us. Things have got to change, because if they don't, they're going to get worse before they get better. This is a rapidly aging population. In 20 years, 1 out of every 5 Americans is going to be 65 or older. And as people age, they live with more and more multiple chronic conditions. And there are fewer caregivers to take care of these people I'm talking about. And then there's technology, the great blessing of our century. Technology can keep people alive, if that's the word, almost regardless of what they want or what state they are in. Now, I want to take a moment to tell you what this is not about. This is not about rationing care. This is not about pulling the plug on grandma. This is not about death panels deciding who will live and who will die. This is about giving people the care they want, the care they expect, the care they deserve, that squares with their norms and their values, and that is patient and family-centered. Now, 90% of the time, when you ask people if they want less care or more care and you explain to them what it is, people tend to opt for less care. But not always. Not always. I was talking to a physician from UCLA. He said he had a woman 90 years old on a ventilator. And every week he would call the woman's daughter. And he would say to her, "Your mother's not going to get better. Are you sure this is what you want for your mother?" And the woman would say, "Doctor, you have to understand that we are a family that believes in miracles." Well, in that case, the family should get the care that they want for their mother. Or take a young woman. Let's say she's 34 years old, she has little kids, and she has breast cancer. She's probably going to fight to the very end with every experimental drug that she can find. And that's what she should have. That's what she should have. Now, what is it going to take to close that gap between what people want and what we give them in America? It's going to take 4 things. Number 1, we have got to do a better job of engaging the public. We've got to inform and educate patients, caregivers, families, so that they can ask the right questions, so they know how they can engage in shared decision-making, so that they can understand what care means, including the option of no care, and also so that they can support reform, health system and legislative reform. Secondly, we have to do a much better job of helping our clinicians, our physicians, our nurses, and others. They are not out to torture patients. They want to do the right thing. They need help with communication and decision aids. They need help to do the right thing and to make dying in America better. The third thing that we have to do is what is often talked about in social change. That is, find out what works. Now, there are several clinical models in America that do work. Most of them are predicated on home-based care. And what they do is they bring the clinician, the doctor, the nurse, and others, to the patient at home. They don't recycle the patient constantly through the hospital. They don't have the patient end up in the ICU. So it's appropriate care at the right time in the right place. And what we need to do basically is to figure out how to create a best practices model out of those programs that work, and then promulgate that model to health systems all over the United States. And the fourth thing we have to do is get up on the Hill and in state capitals around the country and do policy advocacy for legislative and regulatory change so that we can adjust the reimbursement aspects of this program and problem so that we can get all the other things done. People say to me, Bill, this has been dysfunctional for years and years and years. Why do you think that we can change now? Why do you think that we can make dying in America better? And I say, well, I think there are good reasons. First of all, the baby boomers. Now, the boomers are the largest population cohort in American history. These are people born between 1946 and 1964. The oldest boomers today are 67 years old. The boomers are a feisty lot. They're so big that they've always been catered to, and they've reinvented virtually every part of life that they've gone through. The boomers are not going to put up with the nonsense that they saw their parents and their grandparents go through. So I see the boomers as a powerful force for social change. The second thing is the cost that I was talking about earlier. The current system of dying in America is too costly to be sustainable. It's costly for individuals and their families, and that's what they fear the most. It's costly for Medicare and our health system. It's costly for taxpayers. And somebody once said, when something is unsustainable, it tends to stop. The third reason is personal stories, like those stories that I just read you. Everybody's got a personal story. Many of them are about bad deaths. You can go up to Capitol Hill and you can talk to United States senators, people who represent the Tea Party, people on the other side of the spectrum. When you start talking to them about this issue, they say, let me tell you my story. I'll bet many of you have stories. I have a story about my dad. So personal stories are very powerful. They glue it all together. It's not a partisan issue. And then the last reason why I think change is possible is the Coalition to Transform Advanced Care, or CTAC. Now, I co-chair this coalition along with the guy Tom, whose story I read you first about his mother. This is a large and growing coalition with over 100 members, major health insurance companies, health providers and health systems, the faith-based community, large advocacy organizations, consumer organizations like AARP and heart and cancer and diabetes, traditional hospice and faith-based people, and large companies who care about their employees who are caregivers. We have a good sense of direction, we have a good plan, and we have some momentum. And I invite you to go online, take a look at CTAC, and see if you'd like to become involved. And if you do, give me a call. Now, my favorite haiku is this: problems worthy of attack prove their worth by attacking back. Problems worthy of attack prove their worth by attacking back. The problem that I've just told you about is one of those. We're not going to solve this by sitting on our hands. Muddling through is not an option. We can create the change that's necessary to get this done. And the time is now. Now let's face it, none of us are going to come out of this alive anyhow. So we might as well get it done for our parents and our grandparents, and for some of you, our great-grandparents, and for ourselves. Thank you very much.